I'm Kendra. It's nice to see all of you. Some of you may know me, others, it's great to meet you. I have 3 kids who all have type 1, now ranging in age from almost 14 to 21, and they were diagnosed at 5, 8, and 4, respectively. So we are all in our family and have a lot of years under our belt. And I don't ever, I'm never pleased when someone else has a diabetes diagnosis, but I do think the silver lining is the community that you find and meet. And this is a great example of that. So I'm always happy to be part of this and extend the community. So we are really happy tonight to have Dr. Gromit from camp, Dr. Marcie Drury Brown, who is going to be speaking with us. And she's been taking care of kids for 20 years. And we're excited to get her input, her perspective. She is open to kind of any questions that you have that you just like, that question you don't ever have the time to ask, or that you think about after the appointment and you're like, oh, I wish I had gotten information on that. So she's very happy to have like an open dialogue. She's also been really engaged with JDRF research and has a lot of information knowledge about their current research. So that's another potential avenue that she can share her perspective and kind of expertise with us. So if you have questions related to kind of the latest research and the direction that's heading, she's open for that too. So I'm going to let you introduce yourself now too, if you'd like further introduction, and then we can get started.
Thank you. Well, I'm really honored to be here. I joined the Gales Creek Camp Board this past year after being a camp doc for a lot of years. I came off the JDRF board after serving there for 6 years here in Oregon, and I had been on the JDRF board in North Carolina prior to that for a number of years as well. And so the timing just worked out. I was coming off the JDRF board and Rob reached out. And I was like, hey, yeah, I'll go from one board to the next. Let me keep it within the diabetes realm. So, you know, a lot of people ask me like, you know, why did you go into pediatric endocrinology? And I actually went into pediatrics thinking that I would be a general pediatrician. I grew up in a really small town in central Washington, well, actually kind of north central Washington, Okanagan Valley area. And there was one pediatrician in the county. And so I just had that background and thought, yeah, I'm going to be a general pediatrician and we're going to live like in a small place. And that's what we're going to do. And as I went through residency, I mean, I totally affirmed that I love pediatrics, but I realized that general pediatrics wasn't necessarily the right fit for me. And I had never thought of endocrine before. Funny story is one of the ICU docs. I was doing one of my pediatric ICU rotations in residency. And I hadn't even done pediatric endocrinology yet. And they were like, you're going to be an endocrinologist. And I was like, what? Like, no, I'm not. And they were right. I did my endocrine rotation and I loved it. And part of what I loved was really that, you know, a lot of it is outpatient based. It's mostly in the clinic and you tend to have patients for a long time. So you really get to know people. You get to develop those relationships that you get within that kind of general pediatric type of sense, right? You know these families, you get to walk with them through their lives and have that continuity of care. But just the physiology with the endocrine system was more interesting to me, and just it kind of clicked. And I'm a numbers kind of person, so I actually really enjoy diabetes. A lot of people don't enjoy diabetes, but when it came to doing that, I thought it was fascinating. And I just thought that the kids who have it are just so inspiring. You know, they just do so much, and working with the families as well, just, you know, something that was just really struck a chord with me. So, so I've been, you know, doing this for a long time now. And part of what got me into it really was the diabetes. And again, I think like Kendra said, it's not that I wish this diagnosis upon anybody, but if it's going to happen, what can we do to make it the best as possible? How do we try to start with intention, with a positive intention, set our expectations high and really work towards that, and just working with families. And, you know, some people like cruise through and some people really struggle. And a lot of people have some of both, right? And so how do you just walk with the families as they go through that, through the easier times and the harder times, and just trying to be there and be a support to them, not wanting those visits to be dreaded, not wanting to feel like you're coming to get your grade. But you know, how do we see how we're doing? How do we support that? How do we encourage? How do we, you know, again, I love this, the idea of this meeting of hope mongering. How do we create hope, and how do we maintain hope, and how do we, you know, just get through this thing. So that's a bit about me and kind of my background and how I got into it. And it probably gives you a little sense of why I've been on the JDRF and why I'm, you know, been going to camp for so many years. You know, I love camp. Camp's just a ton of fun. And you know, but I found a lot of joy, really joy out of being able to share the journey with families who have kids with diabetes. So
that is a great introduction. Thank you for that. And I appreciate your calling out, because I find as a parent with type 1, even though I have a mom who's had type 1 since before I was born, I never appreciated until I had kids of my own. And I've said this before on one of these sessions, but how much people with diabetes do in the everyday, how much of their brain has to be focused on this, as their baseline threshold is just so much higher in terms of the attention they're needing to pay for themselves, and what rock stars they are. And I kind of read between the lines in mind that, like, you see that too, and you see what individuals with type 1 kind of their resilience in their you know, perseverance with this. And I think it's really amazing and inspiring. And I also am wondering if it's just, I love the story of the ICU doc who kind of called you out as a future endocrinologist. And I wonder, did they tell you what were the markers for that? Like, what did they see in you that made them say that? Because that sounds so, I'm wondering, like, what's the endocrinology type?
Yeah, that's a good question. And I don't know, because I didn't ask at the time. I don't know if they could just tell that I hated the ICU that much. And so do something that's more outpatient based.
Yeah.
Oh, nothing worse than sitting in the ICU and having to watch those monitors. Oh, you know, at least with diabetes, like a blood sugar every hour, you know, it's not like something's going off every 5 seconds.
Yeah. Interesting.
So I don't know I don't know what that was, but I mean, certainly, you know, we do tend to be more outpatient based and not as hospital based. I mean, clearly kids come to the hospital, but the goal is to, like, get them out as fast as you can. What can we do to get them out of the hospital or keep them from going into the hospital?
Well, I'm gonna pause and open it up to see if anyone has any questions they want to start off the night.
Maybe just give us a general overview of what do you see in research that looks exciting that might come in the next, you know, handful of years. What do we have to look forward to?
The next handful of years. That is the hard part, isn't it? So things that are kind of, you know, really more, so when you look at, like, the JDRF, they always talk about their pipeline, right? So the pipeline of research and where they're at in the pipeline, and there's like the preclinical and near, you know, all this stuff. So things that seem to be closer on. The technology side of things is ever increasing, right? And so that part's been cool. I mean, I think even just, you know, in the past 5 years, there's been a total boon in technology. And I think that that's going to continue to advance. And I love that there is a bit of competition, right, between the companies, you know, so one company comes out with one thing, then the next one has to then try to, like, one up it. And, you know, so you see them pushing each other. And so, you know, just the way things have gone, you've got the tandem algorithm. And so Medtronic's, like, you know, set out their 780 algorithm. It's a little bit different. I still don't have a lot of real world experience with that one, but it seems like it could be like a next step up. But then you got the islet where, you know, you don't carb count, you just meal announce. So, like, how's that going? Like, everyone's like, oh my goodness. On the opposite side of the spectrum, you've got tide pool, right? So you've got islets on one side, like, how little can you do and get away with it is the concept I take away from that one, right? How much can you decrease the cognitive burden? And then, like, the tide pool algorithm with the twist pump that's coming out, it's like, how much control do you want to have,
Mm.
right? Like, okay, you can choose the type of carb, you can choose like, do you want to bring your blood sugar down before the meal? Here's the exercise, like, so you've got a couple options there where they're almost polar opposites, but I think they really get at different patient populations, which is great, right? So it's not one size fits all. It's what's right for this person. And I think both of those algorithms are gonna again kind of be pushing the companies to do that next step. Like, all right, Tandem, what you gonna do now?
Mhm.
I know you got Moby's out. It's little. What are you gonna do with your algorithm though? What's next? So I think that's something that we do seem to see some pretty fast turnaround. So when you're thinking like handful of years, that's coming. I think, when you think particularly about families who have established diabetes, right? So it's like stage 4 diabetes. It's what are we doing for, oh, I just blanked on what they call it. Hold on. They call it something. I wrote it down. So I forgot to remember. Oh yeah, they're improving lives. That's what they call that section, improving lives, right? So outside of all this, like, can we cure diabetes? How do we improve the lives while people are waiting for the cure? I think there's gonna have to be more than one cure. Diabetes is kind of like cancer. There's not like one diabetes, right? So it's gonna be more than one way you're gonna have to cure this thing. So that's complicated. So how do we improve the lives? And so they're really looking at how do we, how do we help improve other metabolic control? So type 1 diabetes in particular has been very focused on blood sugars. How do we get the blood sugars down? So that's good. And we're making a lot of progress with that, particularly like with these closed loop algorithms, that kind of thing, so that's better. But there are other aspects like that can be improved upon. So looking at like the GLP-1 agonists. So these are like your Ozempics, everybody's talking about them because they're used for type 2. Now they're used for obesity. In theory, they should be helpful in the type 1 population, right? They're kidney protective, they're heart protective. So these could be really valuable tools in, improving lives, preventing long-term complications. So there are research studies, there are clinical studies going on right now with like GLP-1 agonists, for example. They're also looking at the SGLT inhibitors. And so those are also a medication that's used for type 2 diabetes. I think it's been recently approved for obesity as well. But again, this is something that is heart protective, kidney protective, and it can be a way to kind of improve blood sugars as well. Now, the SGLT2 inhibitors have a black box because they can mask DKA. They cause you to pee out sugar. And so you can pee out so much sugar that the insulin that your pump, for example, gives you go down so much that now you make ketones. So that's a little bit of a problem. So they're finding that, but it's like they're actually approved in some countries. So I think that there's a way forward, but they're looking at, okay, so what if we add a GLP-1 agonist? What if we do that and an SGLT2 inhibitor? So these are studies that are actually going on right now, looking at that aspect. There's a medicine called verapamil you guys have probably heard about. I don't know if you do any of the research stuff. It's a calcium channel blocker, so it's a hypertension medicine. They've shown that it prolongs beta cell function in people. So using that early in diagnosis, that's like a pill that's been around for a long time. It's not expensive. So that's something that may be helpful for our new onsets. I think one of the next steps, I don't have a sense of how soon this will be, right? So one of the things that I've been really interested in is the different types of insulin that they keep talking about. So like glucose responsive insulin, right? It turns on when the blood sugar is high, it turns off when the blood sugar is low. Like, hello, this is like the holy grail, right? Yes. What if you gave one shot a day and it just worked? That would be phenomenal. So they are looking at that's something that I don't think it's quite in the clinical phase. So I don't know if it's in that kind of few years standpoint, but I think that is something that's moving forward. They're also looking at, kind of more like ultra rapid and like liver targeted insulins. They've been talking about those for 3 to 5 years, and it seems like it's moving forward, but it's not necessarily like moving forward super quickly. But those are also really interesting in ways to be able to help the insulin that we give work better. So Those are, I mean, I think when you think about improving lives, they also are looking at kind of supporting psychological and social health. So looking at behavioral health programs that are specific for people with diabetes. So how to help support diabetes distress. I think that's something that we'll be able to move forward over the next couple of years too. And so, you know, people talk about diabetes distress, but there isn't a lot that is out there about what do you do about it. And diabetes distress is, I would say, it's kind of another way to talk about burnout or the burden of disease, right? So how do we, you know, kind of help with that? And again, I don't think it's going to be, like there'll be one answer. I think there'll be, you know, things that help some people and things that help other people depending on the person. And certainly, you know, people have varying levels of diabetes distress over their lifetime. And it's, you know, that's just like being a human, right? You know, sometimes we're really stressed out and sometimes we're not as much. And there's a lot of factors that go into that. So I do think that there will be movement forward in that realm over the next few years too, but how do we help support people who have diabetes? And I think that again, from my standpoint, was really helpful. Like, you know, so what can I do with that teenager who's really struggling? You know, and when you talk to them, they won't tell you anything. So again, I don't think there's necessarily going to be like a magic pill or cognitive behavioral therapy for it, but I think that we'll have some ideas to be able to move forward with. I'm just thinking about otherwise, like other things. It's interesting. I mean, you know, I'll give JDRF credit in that they, you know, used to be totally about cures, right? So like it was all about the cure. And I feel like they've done well to kind of expand that concept and be like, okay, we are still working towards a cure, but we do want to, you know, improve lives and we do want to prevent. And so they've got things to look at that. In the cure realm, so usually that's like under either the disease modifying therapies or cell therapies. Like, I think one thing that's cool is that they've got beta cells now. They either have them or they can make them, right? So when you think about, all right, do we even have the beta cells? You know, can we get beta cells? We can either get or make beta cells. Like that part, that seems to be a check on the box there. The question is like, how do you protect those beta cells from the immune system? And so there's cool research going on from that standpoint, but it is primarily kind of preclinical. There are like a couple like kind of clinical studies looking at encapsulated beta cells and things like that. But I think that, you know, I told Rob the other day, I don't give times on these things. I'm not going to say in 20 years there's going to be encapsulated beta cells because I have no idea how long it's going to take for this to happen. But it seems like, I mean, I've been watching those, like, you know, kind of their research about they've got little YouTube things. So like they're like usually around 30 minutes or so, and they update them every year. I've been watching those for 5-6 years, and you know, you can see like, all right, here we go. We're making a little bit of progress, but it definitely takes time. So
a couple of things. One, SGLT inhibitors are being used now in veterinary medicine. There's 2 that have come in the market in the last year or so for cats.
I was going to say for dogs or cats? For cats. Cats. Because they usually have type 2?
They're more typical type 2, yeah, obesity related. But I'd heard about the beta cell, you know, that they can transfer, or they can modify alpha cells to beta cells in the pancreas. But there was also a study that came out, it must have been in like August or September of 2022, so literally right before our son was diagnosed, and I flagged it because he has a immune mediated disease, and they were taking B cells, so immune B cells, and they were taking them out of the patient, reprogramming them and putting them back in, and they were getting really good responses with other immune mediated disorders, like I want to say lupus and maybe multiple sclerosis, I can't remember, but anyway, I was like, all right, well, there's our solution. We can just fix the beta cells and we fix the B cells and put it together, and we've cured, in theory,
Yeah, they were talking, that was one of the ways in terms of having beta cells. It's like there's a number of different ways you can do it. And one of it is, yeah, you take other cells and you can program them to become a beta cell.
Yeah.
Like, that's cool.
But you can make beta cells all you want if your immune system still keeps killing them,
yeah.
it doesn't help.
Exactly. So how do you protect them without it being complete immunosuppression?
Yeah.
So,
Mhm.
which at this point still has greater risk than having type 1 diabetes. So
Right.
that's where we.
So, I mean, at the time of that publication, there were a couple of patients that were 18 months out with remission of their autoimmune conditions. So I haven't followed up with it since then, but something to look at, and hopefully maybe someday.
Yeah. Well, I do think, I mean, it's some of the things it's going to depend on the person, like how that person got to their type 1. And so like there's a case report where there was like a teenager who had, some like autoimmune thing going on. I forget what it was, but it also developed like blood sugar issues, like a type 1 diabetes situation. And he was given a JAK inhibitor. And his immune, whatever it was, I forget what it was now, it's a couple years ago, got better. And his blood sugars got better, And so now they're looking at JAK inhibitors. There's like a bandit study where they're looking at JAK inhibitors. So that's probably going to help, like if you have this, this one, like maybe HLA marker or something along that line, then this will work for you. But if you don't have that one, then if you have this other one, like maybe then this other thing will work for you instead.
Right.
Oh, I think that
I wonder, I'm sorry. Go ahead.
I was gonna say, I think that in the future, we will probably be HLA mapping people. Like right now, when people, we'll look at like antibody levels and things, but, I think we'll be looking at, okay, what are your markers for type 1? How did you come upon this? And that will help direct, like, personalized medicine, basically.
I was going to ask you, and this is not, and if it's hard to answer without feeling like you're like, I'm not asking from like a marketing or what should we do, but as someone with 3 kids whose pumps have or about to expire, because the iLet is so new, I just wonder now that it's out there with real world evidence, if you have any, like what you've been seeing in the clinic or what you've been seeing with your patients with that pump compared to the other, we're familiar with the other ones and have been on almost all of the other ones. So I just wondered, because it's a departure from the algorithms that Medtronic and Tandem have been using. So I just wondered if you have what your experience has been thus far, or what you've seen.
I haven't had anybody take it up yet.
Okay.
Yeah, I know. I thought for sure, like, I was like, somebody's going to love this thing. And I think part of it is people get accustomed to the pump that they have. And it's hard to change.
Yeah. I am also finding with pumps, because to your point, things are moving so quickly now. I feel more like the stakes are higher in making this decision right now than it has been in the past, because I feel like it's a little bit like when you're at like the cusp of some like big change in cars, and like if I could just hold out a little bit longer, I'm going to get the latest
model
technology.
You're going to change.
And it just feels like you have to commit for 3 years, and over 3 years time, there could be really beneficial new technology out there that you don't quite have access to. I know a lot of them have the software upgrades, so you don't have to worry about that quite as much, but some of them that are real departures, it makes this choice harder than I think it has been in the past when we've been deciding about pumps, because the options they're distinct enough, they're different enough in what they offer that I'm struggling a little bit with the direction, and like the bespoke diabetes cure. I also think the right pump is also, I think even of our 3 kids, like, I think one pump might be better for one of them than the other 2. The other 2 I could see with a different pump. That gets a lot, like that would really ruin our economies of scale on our pump supply. So I'm trying to avoid that because it's really nice to have our big cabinet that everybody can choose from. But it is true that like there might be one that's better for one of them and where the other ones are better for the other. So I don't know. I guess I'll have to go dig around for more real world experience with the iLet, just to be able to compare that as we make this decision.
Yeah, I mean, there's definitely a couple patients where if that iLet had come out 6 months earlier, I'd probably have them on it because they would have been starting on it, but now they're hooked in with the pump with another, then they're hooked for 4 years. And so then it's like, who's changing over, who's interested in changing? Because what I really want to know with the eyelet is, in real life, if you've got a teenager, say a teenage boy, and they just don't meal announce, how well does it work? Because the thing with the eyelet pump is right. It's like, okay, you just meal announce, but you know what? They aren't doing anything.
Right.
So
Right.
my daughter got the eyelet about 2 weeks ago.
Oh, okay.
Talk.
How is it going?
Oh
We'll take an N of 1.
It is totally weird.
Yeah.
It's different. And it was the first week a total disaster. I mean, because it just is different. It learns every day and essentially kind of repeats yesterday, your schedule, and if you, so I can almost not, I don't even know where to start. It's so weird. And we have had some serious lows, like lots and lots of serious lows, because it does little micro doses, like every 5 minutes. It will actually give her insulin every 5 minutes, like if she's high or whatever. And it has led to the first 7 days, the first 4 days are like the training days. You're trying to train this thing. So you have to not eat for every 4 hours. So you eat, you meal announce, which is you get to choose whether it's breakfast, a lunch, or dinner, and within those you get to choose whether it's high, regular, or lower, like bigger, small, bigger, same, regular, smaller. And but you put no information into it ahead of time. You only put the weight of the person, and it only uses that weight calculation for the first 5 minutes, and then it just starts going for it. and so it was actually kind of challenging for her to start, because this whole, you got to wait 4 hours. My daughter likes to she likes to eat all the time, basically, and she used to have a tandem, and she got super good at using the tandem, and for like 6 or 7 years she had a tandem, and so she was quick just doing a little insulin here, a little insulin there. If she was high, she would do a little thing there, and just constantly manipulating the pump, just very manual manipulation. This thing, you can't do anything, you can't touch it. All you can do is meal announce. That's it. And to answer your question, Marcie, if you don't meal announce, it, so far for us anyway, is a complete disaster, because it will take her, she'll go like super high, and then when she's super high, it gives her insulin every 5 minutes, and then it's crash time. Like it is like, and we've had diabetes for, I don't know,
a long time now.
14 years.
14 years, yeah.
And so we've seen the big ones and the small. We've seen lots of things happen. But these lows they've been like, we were exhausted. I told my wife, like, this is like the first week ever we brought her home from the hospital, like, because we were up every night, all night. Everyone was so tired, and everyone was like getting catty.
You start that over spring break? How is she doing with school?
It was the week after spring break. Because we were going to start it on spring break, but we were like going on vacation, and it was going to be a disaster.
Don't ruin a vacation.
No, exactly. And I'm glad we didn't, because just trying to like eat every 4 hours, and then, because you were talking 8 o'clock, noon, 4 o'clock, 8 o'clock, because she's got to eat 4 times a day, because, she plays tennis too. She's on the tennis team. And so and
there's no activity mode. You could raise the target, but otherwise there's no activity mode.
Yeah, and so
that is a drawback.
We ended up, after the first 5 or 6 days, we ended up resetting it. So what you can do is there's a hard reset for the thing, and they recommend that you do it if it's not working out, because it just has total control of you, and you can't do micro things, nothing. So we reset it, and then we started over, and learned a lot from that first week. And the second week was better. She hasn't reset it again. This is like, she's probably in the middle of we're probably 2.5 weeks in, if I think about it. So she didn't reset, and she had a lot fewer lows. And I think it's because she realized the seriousness of forgetting to do insulin, because that was her trademark. With her tandem, she would forget what she would eat. She'd hang out with her friends. They would forget insulin. She would get like Dutch Bros or whatever, and forget, and then she'd go high, but she was good at sort of like managing her way back down without it resulting in a super low. But this, you can't manage your way out of it. It manages your way out of it, and it guesses. I mean, I don't know. There's like,
There's math behind it.
yeah, there's algorithms and math and all that, but often it guesses too aggressively, which is the scary part.
And will that get better over time? Like it should learn to get better over time, but
it's
still.
supposed to get better over time. So let's say that you eat, your normal meal, and it's like, I don't know, maybe it's a bowl of cereal or something, and then that could be.
That's hard because cereal does this anyways.
Yeah, right. That's the thing. Also, it doesn't take into account like the glycemic index of things. So you can eat like an egg and toast, or you can eat like Cheerios, and those are very different. And they'll hit you. Or you can eat pizza, and that's different than eating a sandwich. And so it just kind of has to guess. When it works, it was like there were a couple days there where she was like 90% in range or whatever.
Oh,
like,
sweet.
how did you do that? She's like, I don't know. And then the next day, it's like 15% in range. I'm like, how'd you do that? She's like, I don't know. So it's just super weird. Anyway, I don't know. I keep reminding her, or I did remind her one time during the low moments, that we could return it, like if we needed to. But she's like, no, I think this is really going to work. And
good for her.
I mean, it's so different. So you gotta give yourself time to learn. You gotta give it time.
Yeah.
And with Omnipod, they said it's 3 to 4 weeks.
Well, good for her for like not getting discouraged and like sticking with it seeing, just to really be able to tell if it's going to work for her or not. But it is, that's interesting because I've been like, for one of our kids who is who is more likely to skip meal boluses or do them really delayed, I've been like, maybe this would be the right fit, but it sounds like maybe not.
Well, that's kind of what we thought too when we ended up doing. We were told this is designed for teenagers. This is like a thing where you should be able to eat.
Decreases cognitive burden.
Yeah, all the stuff you don't have to think about. And also, by the way, if she's had diabetes for so long, she never counts carbs anyway, I think.
Right.
I think she's like, that looks like about, and she just punches in like, it's not even like a burden for her to count carbs. She can just eyeball something and know essentially what it means to her, which is kind of like a personal thing, as you're saying. Yes, but we were told like it's a teenager thing. But from my experience, I will say if you forget to meal announce, it is worse so far.
Yeah.
Interesting.
Well, I find also, I don't know if other people find this with pumps, but one of the things I find, which I wish a pump, I feel like they can do so many things, they could figure this out, but like a high, every high is not the same. Like I find when our kids are having like a real high, like their sight fell out and they're like HIGH, that high it will overcorrect when they get really high, but the correction, their sensitivity factor works for every other kind of high or fluctuation that they have, but really high highs, it's like an overcorrection, which I think is interesting. And I kind of wish there was like I wish you could change the sensitivity factor if it's correcting for above or below certain thresholds. I also find, and other people may have this too, that the same thing happens with new sites. Like when they put a new site on, they are so sensitive. And then that insulin sensitivity factor is like, the last day, the sensitivity factor needs to be like doubled. And the first day it needs to be halved. And I get it. It's like a crude metric, but I'm like, it could figure that out. Like it knows when it filled a new cannula, it has a new site on. But that, like, all that is to say is there's so many different nuances in their systems physiologically that are happening, and the best pumps, even as smart as they are still kind of like a crude tool for mimicking what our bodies do naturally. But
and that's where some of it is, it's like the insulin itself, right? And so the insulin isn't quite fast enough. It's not on fast enough, not off fast enough. So you need like that more ultra rapid insulin, where it doesn't last as long.
Right. In and out. Like it brings it down, and then you don't have to worry about those prolonged. Yes, exactly.
Yeah.
Exactly.
We need that.
But I'm with you that the glucose sensitive insulin, that's what I'm waiting for. That's gonna be my Shangri-La.
So cool.
It's our granddaughter who has type 1, and one of the things in reading the email, it said that you had a unique approach to care. And so I was wondering what that was.
I'll tell you why I wrote that, because because I work with a lot of endocrinologists. Like, we have at least 16 per year, and pediatricians, endocrinologists, and people who work with children with diabetes. And I talk to them a lot. I talk to them personally about my own daughter with diabetes. I talk to them about other people's. I just talk to a lot of them about it. And when I talk to certain doctors, I get a totally different impression about how they approach how they care for their patients, how they talk to their patients about diabetes. And I got that. And every time I talk to Marcie, I get this, like, she's very different at how she speaks, how she talks about it. And I would say, I sort of told her this too, that it depends on which hospital system they come from too. So it kind of almost, I'm wondering, and I asked her this and she didn't really have a straight answer, but whether it's like a workplace culture thing, like, because Dr. Mustache Jean, he also has a very different approach as well. He works at Kaiser. Marcie works at Providence. Some of our other doctors work at OHSU and other ones work at Legacy, and they all come at it from a different sort of point of view. And so Marcie's our only one at the moment from Providence, or at least the only one who has come on to our show. So that's why I was like, she's just different. And I asked her, I think specifically, like, when we were diagnosed, this was years ago, it was actually, I'm from New Mexico, and my daughter was born in Santa Fe, and we were diagnosed, I always say we, I don't know why, but because it happened to all of us. So she was diagnosed in Santa Fe, and then they they were going to try to fly us there with a helicopter, but it was like February 22nd, like snow, like there was probably 6 inches of snow on the highway, and they sent an ambulance. And through all the snow, it was insane, but it was that important that they needed her at UNM, University of New Mexico Hospital in Albuquerque, which is about 60 miles away, at a descent of 2,000 feet. And it was, and Santa Fe 7,000 feet, Albuquerque is 5,000 feet, which is like Denver. So it was like insane, so much snow, and the helicopter wouldn't fly, so they drove her down in this ambulance, and the driver, I'm not even kidding you, he came up. I was like in shock, how a 32-year-old dad is when his daughter's like, they keep saying, I tell the story, they kept saying she's in DKA, and I didn't know what DKA was, and they would say it fast, like, she's in DKA, and I was like, she's in decay? Like, what does it mean when someone's telling you your daughter's in decay? I was like, she's 2, like, what? It was like super traumatic, and then this ambulance driver who had just pulled in his like red hot ambulance was like, hey, don't worry about it. My son was diagnosed when he was a kid too. Now he's got a scholarship to some football team, like in a college scholarship for football. And it was like, everything was just so weird and surreal. And then he gets in his ambulance and takes my wife and my daughter, to Albuquerque. And like, it was super crazy. And I have a Jeep, and I tried to keep up with this guy, and there's no way. He just, like, these red flashing lights just disappeared into the snow. I couldn't keep up. And anyway, we got to New Mexico, we got to UNM, and it was just like a total blur, and they were already in there. And the way the doctors, it's a teaching hospital, which I think is also very different, but the way the doctors talked to us was weirdly impersonal, and weirdly there were lots of students who kept coming in, and like all the thing, and it felt so like disconnected from like the experience I was having, or she was having, or my wife was having. And then when we finally talked to an endocrinologist, they had this approach of like, yeah, well, this is happening, and it's lifelong, and she'll be fine, and just take care of her in this way, and okay. And we were like, well, but like, what, is there anything that we can help? I remember we asked this endocrinologist, is there like because they were like, you got to do the math, and then you got to do that. There was like, we didn't have pumps were super basic in 2010 or whatever. And so, here's that, you got to do the math on the syringe, and you got to do math on the carbs, and you got to do math on our correction factor, and all this stuff is just math. And I was like, is there like an app for this? And remember the iPhone came out in like 2008 and this was 2010. And the doctor was like, oh, no, we don't do technology. Like, no, there's no, but there was already apps for that. Like, and we were like, man, this is just terrible. It was just so bad. It was like a really bad experience. And there was no warmth and there was no compassion and there was no like recognition that this was like a terrible, thing for some to happen to a kid, or and so I always think about the experience of being diagnosed and like, what do you guys all get together in a room and go like, okay, here's how we typically are going to deal with whenever there's a family that comes in, because you're an endocrinologist, you deal with lots and lots of other things too, I'm sure. But like, I always wonder, like, is there like a team meeting ahead of time, or is I don't know.
There is
The reason I wrote that was a extreme long tangent. I'm so sorry for that.
There is a surprising dearth of training on how to deliver bad news. I mean, there is some, and there may be more than there was when I went through, but there's not a lot really on how to do that. And I will say that we get a little bit numb to that diagnosis, right? To that, and that being such a life-changing, like, bad diagnosis. Because I can think of way worse things, right? But I don't want to minimize anything you're going through. But there, I'm like, ooh, could be like, and but then you, like, when you think about that, it's such a impactful, like, lifelong thing to have. It's a big diagnosis. I don't want to use the word bad because I don't want to. And so I do think that as you head into that, a lot of times ICU room, that you have to, like, remember that for this family, like, they haven't gotten this before. Like, this is totally new, right? And this is a big thing. And just trying to meet them where they are. Some people are overwhelmed. Some people are information seeking. I like to remove blame or guilt, because almost always there's some parent guilt going on. What could I have done differently? Did I cause this? So I always like to, like, you didn't do this. This isn't anything you did. And I always want to have them have hope again, and like that positive expectation from the beginning. Not that it isn't going to be life-changing, but there's no reason we can't plan for the best. How can we do this the best? How can we help you the best? So I think part of it does get down to probably like personalities and things, and what, how what is the overall person's personality, and how do they interact or connect with people. Certainly some are better, some are worse than others. But I think part of it is just, you have to remember that you might have done this 100 times or 1,000 times, but this family hasn't. And so how do you be present for them and kind of help them, again, kind of get through this, whatever stage of thing that they're at, try to find that out and meet them there. As you started, you talked a little bit about kind of culture and things, and I do think I don't think I've always been this way, but I do like the culture at Providence in regards to the mission of caring for the poor and the vulnerable. And there's something that we have, it's called the Providence Promise. And if you've been at Providence, I hope you experience this. Can't always promise it, but I would hope so. It's know me, care for me, ease my way. And so the concept is, really wanting to help people. This applies to our patients, but as well as each other. So other caregivers. And so that sense of wanting to be able to, figure out, learn about people, know what they need, understand them more, and to be able to ease their way. How can we help? How can we make this a little bit easier? How can we make this a little bit better? What can we do to ease somebody's way? that may be a little bit of what you're sensing as well too. I don't know. So a little bit of that promise there that we try to uphold. I really do appreciate your story though too, Rob. I think it is, I mean, even like for me, it's such a good reminder of like, yeah, what is DKA? That is one that I do try to explain to people because it's like, yeah, what are they saying? Nobody knows what DKA is. But you know, how do we, you know, so how do we meet them, you know, kind of help people where they're at and figure out what they know and you know, a lot of times there's misunderstandings again. And like I said, there's, you know, parent guilt, right? There's, you know, that's like a default for parents, right? What did I do? How did I, you know, so how do we relieve parent guilt and then help them see like how they're going to get through. And we have pretty standard ways of treating, but I think you do have to take each family in mind, right? And so what, you know, looking at, you know, what's the home situation like? What is the school like? What kind of supports do they have? Is, you know, like you said, is somebody really challenged with math and we need to try to make this simpler from that standpoint? Or is, you know, is this parent an engineer and they're looking for that app, or how can they, you know, how can they dive in? So how do we, you know, help them with that? So
I was just curious, since there's multiple here with kids, like my daughter is 14 and she is in that friend roller coaster of like, how do I not make it known that I'm super diabetic, because she's very private and doesn't like to see it. So of course then she like eats lunch, but like can't get her phone out because that's like against the rules at school, even though she has approval from the school to have her phone for medical purposes. Like then it's weird because some staff members don't know, and like some kids will give her a hard time. Like, how do your kids navigate that? Like, I need to be in good control. I know I do, but I'm gonna forget because I don't want to make it obvious. Like that whole, how do you do that? I'm also type 1, but of course I didn't get a pump until I was a senior in high school. So I spent 10 years on shots. Like it was just a very different situation. I didn't have a sensor until my second kid was born, you know, like it was just a very different for me growing up. So like, how do you guys do the teenage years of the social weirdness?
She go to the bathroom before she has lunch and just bolus from the bathroom from her phone? Where would it be seen?
Yes, although they limit the number of kids in the bathroom. And so like it's a whole thing. But then
you only have so much time for lunch, like this long for lunch.
Yes. And so like she's her doctor, after me cluing her in via, you know, my chart things like, hey, can you talk to her about this? Because like if I say it in the middle of the doctor's appointment, then I'm like, you know, so like I have to clue the doctor ahead of time the things that she needs to say. And the doctor is helping her because I'm trying to have her take charge of her own care, so that way it's a her thing and not like mom telling her what to do. So like she's getting slightly better, but
Well, I was just going to say, and I think other people might be able to speak to this better because our kids have been very, just, I think a lot of it is personality, but they have always been super uninhibited with their diabetes diagnosis and their care at all ages and as high schoolers. And I know she has a mom with type 1, so it is normalized, but on the other hand, you know, it's a different relationship. Like, I'm wondering if she has other either peers or like slightly older mentors who could help build her. I mean, if people have different levels of privacy that they like, but I guess one thing I wish for her is to just know how, like she's a superstar. Like she should be really proud of this, like everything she does to take care of herself. And that's not always the way that they see it, but I would want her to internalize that too and potentially help her feel less, I'm not saying that she is ashamed of it at all, but just that she's private about it and feel more free to be more open about it, because it is such, she should feel so strong and empowered by all she does to take care of herself. But I think people have different personal preferences for how much they like to share. So other people might have better examples of kids who have similar kinds of sensitivities or privacy preferences.
Our son isn't teen. He's just about to be 9 now, but he was diagnosed when he was 7. And he was out of school for a few days. When he came back, the kids all circled up because we were there. We dropped him off, and he gave a presentation. It was, to him, it was all out there, open. This is what I've got.
He got to go to the hospital for 2 days and watch movies and play video
Oh,
games.
I know. Yeah.
Awesome.
So for him, that was an awesome thing, kind of. The poking thing, not so much. But what I noticed is that the other kids, hearing the whole story, they treat him more like, oh wow, you're so brave for, you're getting poked for, in getting your glucose checked and all of these things. And by laying it out there, it ceased to become a conversation after that first week.
Mm-hmm.
So I know that's a hard thing. Teenagers are completely different, sort of thing. But I think she might not be giving herself enough credit by, if she lays it out there, I think it'll be a very different experience. It's just having that moment of, okay, maybe this will be all right, sort of thing. And I don't know why
That's
it's giving
exactly what happened. That was exactly what happened. My teacher, when I was diagnosed as a kid, was also type 1. So the entire class knew about it. And so, of course, back in my day, 32 years ago, you stayed in the hospital for a week.
Mm-hmm.
You walked out very kind of in control. You knew what your rates were. You had practiced for a week on what to do. And so, like, for kids now, they're in a hospital for a couple of days. And I can't imagine parents that aren't type 1 going home overwhelmed with the whole idea of that. Props to you guys. Like, it was having to like relearn how to do it 20 years later, but like, I can't imagine. So like, for me, I was very much like Kendra's kids. It was never a problem with me. I talked in front of my class of all the kids. Like, it was never a thing. But now with all of the social media and stuff, and she was diagnosed the summer of COVID year. So like all of she wasn't back into the classroom like normal, and like there was a whole weird stuff going on for her anyways. But so I just didn't know if that,
could she have a sleepover with a couple close friends and kind of have that session there where she feels comfortable?
She does. Luckily, about 6 months after she was diagnosed, a friend of hers was also diagnosed. So they've kind of been together, but her friend is very much like, I don't care, everybody can know, it doesn't matter, kind of thing. So it's very kind of, and she goes through spurts of being okay, and then being very hidden, and then being okay, and it's kind of like whiplash mom. I get used to her being okay, and then she doesn't. But I just, it's just that roller coaster that's, and it's a lot of data overload, and I know kids probably all get tired of the data overload, but
well, I went in the email that Rob sent out talking about Dr. Mustache and his award, there was a clip you shared, and I listened to that, and it was really impactful for us to realize that 14-year-olds still aren't ready to manage their own diabetes, and I was like, that's a great point. I need to, over index on the support and help, and not necessarily just hand it off to him. So that was because it is a lot of mental load that you don't realize that you're carrying, that you're trying to hand off because you don't want to carry it anymore, but we can't expect them to take it on just yet.
Yeah, it is. And I don't know, Kendra, have with 3 in the household, I don't know how you do it either, because just having myself and 1 child, it's a lot going between like managing your own and managing your kids, and like she's self-sufficient, and I wanted her to be capable of that. So when she goes off to her friend's house, things like that she can be as self-sufficient as she can. She sleeps like the dead. So that's always
Mhm.
interesting when you're at a friend's house, but that's a
Yeah.
whole nother beside the point. But like, you know, I try to, she knows how to carb count fully. When she's home with me, a lot of times I'm like, hey, it's 52, Meg, or, you know, like,
Yeah.
so that way
Yeah.
it's like reducing the load when I can.
Yeah, she can do it, but she doesn't have to do it always.
Right.
Yeah, I think that's right.
Yeah.
Yeah.
Kim, has she ever talked with like a behavioral health provider about it?
She has not. I have suggested it, but she's always turned me down. And I'm hoping that with her endo starting down the path of talking about that, like she excuses me from the room, and so they have private conversations. And I'm hoping that that maybe will open the door for her to be more open about it, because she's refused at this point.
Yeah, because sometimes that's helpful. They can kind of help people map that out. But Shelley, you had your hand raised a moment ago too. Did you have something to add? I was curious what you were thinking.
Well, so my grandson, who's now 6, was diagnosed at 3.5. And when he went back to preschool, he was very open. We brought him some books that he was excited to share with his friends. He showed when he first got his pump, he couldn't wait to show everybody his pump. Well, now in kindergarten, all of a sudden he's become very private and does not want to talk about this, even with any of us. And so, you know, the teenage years, we kind of think, oh boy, now what's coming if this is hitting him so early. And recently he told his dad, he said, I just want to be normal. I don't want to be like this. I just want to be normal. So any guidance, I mean, we're always looking for books that maybe he'll feel comfortable to take to kindergarten to share. His teacher is very open to trying to talk to the other kids when he's ready. But just you know, any suggestions on how to kind of get him back to where he was. Very eager to teach his friends about his diabetes.
Do you have the book by Sonia Sotomayor?
Yes, absolutely. He's got 3 copies of it.
Oh, well, there you go.
He hasn't read one of them. It's a beautiful book.
Yeah, I just love that. I mean, she talks about her own journey, but I think part of the thing that sticks out to me is that nobody's normal. Everybody has something, you know, and typical kids get teased too. My, you know, Rob put in the thing, I have celiac. I've had it for a long time now. My daughter was diagnosed as well. And it's something that she's sensitive about, and, you know, being teased about not being able to eat gluten, and, you know, and so I'm like, well, remember, you know, like if you're getting teased about this, you know, are you teasing anybody about something? And just, you know, everybody has something. So like, help this, you know, let this help you be a, you know, a kinder person. But I would wonder, like, for your grandson, did he get teased about it or something?
No, we don't know.
I just wonder, because that's right around the age where you see kids starting to point out differences.
Right.
You know, so I wonder if maybe
he's very close to the vest anyway. You know, he's very close to the vest. And you have to kind of gently, you wait for when he's ready to start sharing things with you. So we're trying not to push him, but let him know that we're willing to listen when and help him with this. But yeah, and there might be a situation at the after school program where he's going to, there are signs that he might be, one of the older boys might be bullying him a little bit. And so they have to do with that. So my daughter's working with the after school program there to see if they can keep an eye. But yeah, it was very distressing that, you know, he's done this 180 on top of his blood sugars just being totally out of control, you know, not playing by the book. 2.5 years later, it's just not fair. Just not playing by the book. So yeah. Thank you.
And I'll just, my 2 cents about my daughter, and she was diagnosed at 2, so it was and she wasn't really shy at first, but she has definitely gone through cycles of being very private about it, and then other times she's not. She just flaunts and wears the thing, you know, on the outside, and the pumps hanging on the outside, and it's just weird. It goes in cycles, and It
Yeah.
has to do with, whatever's going on in her life, whatever her friend group
Yeah.
is doing, which friend group she's a part of. I just think there's just so many changes that constantly happen, and they'll eventually settle into, I think, I don't know. But I agree, Kendra, it's very personality based, but there is definitely hope. If she's private now, she might just be next year. Just next year, she might be like, yeah, whatever. I wear my pump on the outside, and people ask me, and I tell them. So, anyway, thanks everybody.
Thank you.
Thank
Thanks,
you
everyone.
all.